Namaste and welcome to this deep dive. Now, if you're anywhere in the veterinary medicine field, you know exactly how incredibly frustrating fungal infections can be to deal with. Well, today, we're completely decoding veterinary antifungal pharmacology. Think of this explainer as your complete, go-to textbook guide. We're going to walk through all the crucial antifungal drugs, how they actually work, and their clinical uses, step by step. Oh, and real quick before we jump in, we've got Hindi subtitles available for this video, and we're bringing you all new generated visuals in sequence, so no blurry PDF images here. Okay, let's take a quick look at our agenda for today. We'll kick things off in Section 1 with fungal infections and classification. Then, Section 2 covers polyene antibiotics and benzophorins, followed by antimetabolites and imidazoles in Section 3. Moving on, Section 4 is all about triazoles and alliamines. Section 5 gets into echinocandins, iodides, and others. And finally, Section 6 wraps up with clinical uses and treatments. Let's get right into it. So, Section 1, Fungal Infections and Classification. Understanding the pathogens in our arsenal. Because let's face it, before we treat a disease, we really need to understand the enemy.
So what exactly are fungi? Well, they're eukaryotic organisms. This means they have a true nucleus, mitochondria, and a very rigid cell wall packed with chitin and a lipid bilayer that's mainly composed of ergosterol. Now here's the kicker and why they're so tough to kill. Unlike bacteria, fungal cells are actually pretty similar to mammalian cells, the cells of the animals we're trying to treat. The main difference? Mammals have cholesterol, while fungi have ergosterol. Because they're so fundamentally similar, treating fungi often carries a much higher risk of toxicity for our animal patients.
All right, let's dive into this. When we look at fungal infections, or mycoses, in animals, they basically fall into two main camps. First, we have superficial infections. These affect the keratinized tissues, think skin, hair, and nails, or mucous membranes. We're usually talking about dermatophytes here, like microsporum or trichophyton. In general, these are much easier to treat. But then we have systemic fungal infections. These guys invade the deeper tissues and organs, like histoplasmosis or blastomycosis. They might have low invasiveness overall, but make no mistake, they are often life-threatening and extremely difficult to treat. The stakes here are incredibly high. Now take a look at this massive classification of our antifungal arsenal. It's a lot, right? But it's absolutely crucial to know. We've got antibiotics, like the Polyenes, which includes Amphotericin B, and benzopurins like griseofulvin. Then we have antimetabolites like Flucytosine. Down the list, there are the Azoles, both imidazoles and triazoles, giving us heavy hitters like Ketoconazole, Fluconazole, and Itraconazole. We also have synthetic allylamines like terbinafine, and lipopeptides known as Echinocandins like Caspofungin. And finally, some miscellaneous traditional agents, acids, dyes, and iodides. Don't worry, we're going to break all of these down. Moving right along to Section 2, polyene antibiotics and benzofurans, disrupting membranes and microtubules. These are some of our oldest yet most potent weapons.
And this brilliantly illustrates exactly how Amphotericin B works. It's a fascinating sequence. Step 1. The drug binds with high affinity right to the ergosterol in the fungal cell membrane. Step 2. This interaction physically creates channels, or pores, right through that membrane. Step 3. Because of those holes, the membrane's permeability is critically altered. Step 4. All the essential cellular contents, like potassium and hydrogen ions, just leak right out. And finally, Step 5. This massive loss of vital molecules leads to irreversible damage and ultimately fungal cell death. It's a seriously powerful fungicidal mechanism.
But there is a huge catch. That incredible power comes at a steep price. Amphotericin B is highly toxic. It's absorbed very poorly from the GI tract, so for systemic infections, we have to use it intravenously. The biggest red flag here? Severe nephrotoxicity, or kidney damage. It actually causes renal vasoconstriction, which cuts off blood supply and tanks the glomerular filtration rate. It can also cause anorexia, nausea, arrhythmias, and thrombophlebitis. Because of all this, it's strictly contraindicated in patients with renal insufficiency, unless, of course, the infection is immediately life-threatening. You have to use extreme caution.
Now, sticking with this section, let's look at griseofulvin. Unlike Amphotericin B, this benzofuran is used strictly for dermatophytes, those superficial infections. Its mechanism is pretty unique. It disrupts meiotic spindle formation, basically stopping the fungus from multiplying.
But here's the coolest part. When given systemically, it actually accumulates in the keratin precursor cells. That means as new skin, hair, or nails grow in, they're literally built with the drug inside them, blocking the fungus. That's exactly why you have to keep dosing dogs, cats, or horses for weeks or even months until all that old, infected tissue is completely shed off.
All right, Section 3, Antimetabolites and Imidazoles, cellular sabotage and enzyme inhibition. Let's see how we can mess with fungal DNA and sterol synthesis.
Okay, check out Flucytosine. This drug is basically a molecular Trojan horse. Step 1, Flucytosine enters the fungal cell through a specific gateway called cytosine-specific permease. Step 2, once inside, it's rapidly converted by the fungus's own enzyme into 5-fluorouracil, or 5-FU. Step 3, this 5-FU competes with uracil, forming rogue metabolites like 5-FUMP and 5-FUTP. And step 4, these metabolites completely sabotage pyrimidine metabolism, bringing RNA and DNA synthesis to a grinding halt. And the best part? Mammalian cells don't have that permease gateway, which neatly spares the host from immediate toxicity.
Next up are the imidazoles, which work by inhibiting the enzyme 14-alpha-demethylase to stop ergosterol synthesis. Ketoconazole is our prototype systemic azole here. It was a real game changer because it could be given orally. But it comes with a major clinical warning. It suppresses testosterone and cortisol production and can cause hepatotoxicity. In fact, that endocrine side effect is so strong we sometimes use it to treat Cushing's disease instead of fungi. We also have topical options here, like Myconazole, which is great for local ringworm but can cause itchiness in adipic dogs, and Echinocandins, which actually has a vapor effect, making it fantastic for disinfecting poultry facilities.
Let's move to Section 4, triazoles and allylamines, broader spectrums and newer synthetics. These are the improved, safer upgrades to our older drugs.
The triazoles are incredibly popular in modern vet med. Let's compare Fluconazole and Itraconazole. Fluconazole's superpower is its distribution. It's absorbed perfectly regardless of food or stomach acid, and it completely penetrates the central nervous system, even the CSF and the eye. This makes it absolutely brilliant for treating cryptococcal meningitis. Itraconazole, on the other hand, has a massive, broad spectrum. It's highly protein-bound and extensively metabolized in the liver, making it the absolute first choice for those stubborn, refractory ringworm infections in cats. Oh, and there's voriconazole too, great for invasive aspergillosis, but watch out, it is phototoxic.
Then we have the synthetic allylamines, like terbinafine. This is a fascinating two-pronged attack. Step 1, terbinafine selectively inhibits an enzyme called squalene epoxidase in the fungal cell wall. Step 2, this immediately halts the production of ergosterol, so the fungus is starving for sterols. But wait, it gets worse for the fungus. Step 3, because the pathway is blocked, toxic levels of squalene start building up inside the fungal cell. Step 4, this toxic buildup literally bursts the cell from the inside out, causing cell death. It starves them and poisons them. Incredible, right?
Moving on to Section 5, Echinocandins, iodides, and others, cell wall inhibitors, and traditional remedies. Here we contrast the cutting edge with the elemental. Check out Caspofungin. This is an echinocandin, and it represents some really advanced tech. It works by inhibiting beta-glucan synthesis in the cell wall. Since mammalian cells literally don't even have the glucan synthase enzyme, this drug is highly selective and very safe for the host. We use it IV for severe candidiasis and aspergillosis. Contrast that high-tech approach with a classic, sodium iodide. We still use this elemental treatment for cutaneous sporotrosis. It works, but you have to watch closely for iodide toxicity. Look out for signs like heavy salivation, scaly skin, and a racing heart or tachycardia.
We also have this whole toolbox of miscellaneous topical agents. You've probably seen these in the clinic. There's benzoic and salicylic acid used in Whitfield ointment as keratolytic topicals. We've got undecylenic acid for microsporum, and dyes like gentian violet that work as surface antiseptics. Tolnaftate is another one that inhibits squalene epoxide, just like terbinafine, but strictly topically. And don't forget copper sulfate, a classic astringent fungicide used for cattle ringworm. They might be older, traditional remedies, but they still get the job done for everyday superficial mycoses.
And finally, we arrive at Section 6, clinical uses and treatments, the first choice therapies. Let's tie all this pharmacology directly into practical clinical decision-making. When we're dealing with superficial infections, what's our first line of defense? Well, for dermatophytosis, your classic ringworm caused by microsporum or trichophyton, topical therapies are usually all you need. We're talking topical azoles, cyclopyrrhics, or haloprogen. If you're dealing with a skin yeast infection like Candida albicans, topical azoles or Nystatin work great. And if that Candida is in the mouth or intestines, Nystatin is perfect because it isn't absorbed into the bloodstream. It just passes right through the gut, doing its job exactly where it's needed.
But when an infection goes systemic, everything changes. These are the life-threatening cases. For cryptococcosis, the first choice is the heavy-duty combo of Amphotericin B and Flucytosine. For severe aspergillosis, it's Amphotericin B. Got a case of blastomycosis? Itraconazole is your best friend. For histoplasmosis, you're looking at Amphotericin B or Itraconazole. Notice a pattern here? Amphotericin B and Itraconazole are the absolute heavy artillery of veterinary medicine. You constantly have to weigh the severe toxicity of Amphotericin B against the absolute necessity of saving the animal's life.
So the crucial point is knowing exactly which drugs go where. Systemic agents like Amphotericin B, Flucytosine, Fluconazole, Itraconazole, and terbinafine travel throughout the entire body. But then look at our topicals, natamycin, clotrimazole, salicylic acid. Now, you might notice some overlap like Ketoconazole or terbinafine. That's because they come in different formulations. You can give a terbinafine pill for systemic reach, or slap on a terbinafine cream for localized issue. It's all about choosing the right delivery for the specific threat.
To wrap our heads around all of this, I want to share a quote that perfectly summarizes this topic. In general, fungal infections are more difficult to treat, are slowly eradicated, and the antifungal drugs are more toxic to host than antibacterial drugs. That right there is the harsh, textbook reality of veterinary pharmacology. You can't treat fungi like bacteria. It's a completely different, much tougher ballgame.
Which leaves us with this final thought. As fungi continue to develop resistance, literally mutating their sterile pathways and decreasing their drug uptake, how will the next generation of veterinary medicine stay ahead of these complex eukaryotic pathogens? Are highly targeted drugs like the beta-glucan inhibitors the only way forward? It's a huge question to ponder. Thank you so much for joining me on this deep dive into antifungal pharmacology. I hope it gave you some solid insights for your practice.